The first part is Mr Carton is going to, with the assistance of Craig, is going to show us how to examine the hip joint. Second part of the session then is looking at the conservative as opposed to surgical management of FAI, which I think will be very interesting and should lead to some interesting panel discussion. Okay, thank you.
Okay, guys, the way we're going to run this is we're going to have a live video feed on the two televisions, and we're going to, David is going to present some of the ranges of movement, and there's going to be some slides just showing exactly what we're doing here as well, so everybody can see it. Sometimes it's hard to see what I'm doing. No matter if I stand on that side, you can't see anything. If I stand on this side, you probably can't see what I'm doing either. So hopefully you'll get to see the examination. What we're going to run through is just this is a typical examination of what we do whenever a patient comes to my clinic. The types of patients who we generally see from an athletic point of view will obviously, most of them have no arthritis. Unfortunately, there are quite a lot who do come through with arthritis, but we're focused on the non-arthritic hip here. Mainly FAI, hip impingement, laxity and instability, and a posterior hip pain, okay, which is also very common. So they're the three things we see on a regular weekly basis. Just going to run through a systematic approach to examination. The next slide there. So first of all, range of movement. You can see from the slide here, David will take you through just the figures.
The average patient mean, so 111 for the patient mean in the clinic and 123 compared to the average population non-symptomatic person.
Okay, so when you're assessing flexion, it's very important that the patient's relaxed. It's very important that when you're bringing the knee up, you bring it up in line with the ipsilateral shoulder. What happens in impingement, if you have deformities, there's a tendency for the hip to go out, and it'll give you a false range of flexion. Okay, so very important to bring a straight line flexion is what we measure. When you're measuring movement, and if you're looking after players, doing any screening at the start of the season, it's very important that you always measure with two people. Okay, the person, the operator should be holding the patient in a passive movement, while the second person would be using a goniometer to measure the movement. If you try to do it all yourself, you will not get a reproducible movement. So it's very important. So inflection is really all about just bringing up to that natural end point, holding the knee, and then taking your measurement. As David said, our patients have a mean of 111 degrees compared to the population average of the same age, between 25 and 35 years of age, which is 123. So significant a restriction with flexion in impingement patients. Next, we go on to abduction and adduction. So with abduction, again, it's very important that you stabilize the pelvis. I always hold the contralateral side of the pelvis, and you bring the hip out until you feel the pelvis moving. Okay, so I'm not even looking; I can feel it moving. If you don't do that, the hip will keep coming out. Okay, and so you'll get again a very false measurement. Okay, so you have an operator then who measures the angle between the side of the table and the leg. And so adduction, again, ipsilateral side, stabilize the pelvis, and you're bringing the leg right across the abduction. What we don't do is we don't do measurements in this, because you've got to go into flexion and internal rotation. So we don't tend to measure adduction with the patient supine. We measure adduction with the hip up into 90 degrees of flexion, and then we ask the patient to relax and drop the knee to the contralateral side. As the knee drops in, again, you've got to stabilize the pelvis, or else you get a false measurement, and then we measure from the vertical to the leg at the adduction level. And you can
see about 10-degree difference between the normal population mean and the patient mean. So 20.5 for patients compared to about 30.5 for a normal population mean.
So again, a significant deficit in adduction on average in all of our patients who attend with impingement to the clinic of 10 degrees. So again, the second movement that's affected by FAI.
Abduction less severely affected, so 44 for the patient mean compared to 46 for a normal population mean.
And the reason abduction is not affected by hip impingement is because any bony deformities in the hip, when you're bringing the leg into abduction, you're bringing the deformities away from the rim of the cup. Therefore, it doesn't affect it. Okay, so therefore, abduction is not affected in any of our patients with FAI. So internal rotation, again, it's important bringing the hip and the knee up to 90 degrees flexion. This is the movement we test internal rotation, and holding the knee stable, we're bringing the foot outwards, rotating the hip inwards, okay? Now, if somebody has some instability or some laxity of the knee will keep coming. As you see, the hip has stopped, the knee is coming. So I can make this internal rotation more if I want to. So it's important that you bring the knee a little bit more into extension, just above 90, and as you internal rotate, you'll get a true measurement. Bring it back down and measure it, okay? So, but not putting force. The knee often in a stiff hip, you can sit and do this here, and it's actually the knee that's moving, not the hip. So if we look at external rotation, same position, we're trying not to go into abduction. The risk is that the hip starts coming out in somebody who's stiff. So holding it straight, true external rotation, and we get a second person in to measure that range while we're holding it. And it's all passive, okay? Again, you can do an active range of movement as well, but it's harder to keep everything stable with the patient doing it themselves. Again, you can have the patient sitting up at the edge of the table, like we have there, and again, just getting down, and very simple, stabilizing the knee, your pelvis, you're ready at 90 degrees, and simply moving the hip, you get your internal and you get your external rotation. Okay, so
yeah, external rotation is actually, our patient mean was a little bit higher than what the average population mean is, so 37.8 for our patients and 33 for the population mean.
So what the results show is that hip flexion, hip adduction at 90 degrees flexion, and hip internal rotation are the three movements that have significant restrictions in all of our patients on average who come to the clinic. But external rotation is not affected. Again, you're moving the deformity away from the joint, the hip is coming outwards, and the cam is moving away from the pincer, okay? So, but internal rotation, you're maximizing that, okay? Okay, so what we move on to is then provocation tests. These figures, by the way, all these numbers are based on about 1,600 consecutive athletes who have come and undergone surgery in the clinic, okay? So these are surgical patients, not people who don't need surgery, okay? Okay, hip extension. Again, extension is something that's very important. In the last few years, we've started measuring extension on all our athletes. Before that, it's not published, it's not talked about, but I feel very much that when you have a strong pincer deformity, it tents the anterior capsule, and when you tent the anterior capsule and you try to extend the hip, then it's much more restricted. And we see that very clearly. We see improvements in extension once we've removed deformities in the hip. You can do this on their side. Okay, so basically, again, the important thing about extension, again, is stabilizing the pelvis, keeping the legs straight. We always measure extension when it's straight, and bring the leg back, okay? But you see, we used to measure this way, but the pelvis, even no matter how hard you hold the pelvis, it moves with you, okay? You can release the tension a little bit by measuring with the knee flexed, but again, the pelvis moves, okay? So again, we prefer to measure it straight, but it's harder to control. So we get the patient to lie completely prone. And again, with the leg completely straight, you're stabilizing the small of the back, keeping the pelvis completely flat, and you ask the patient then is the one where we do gently, actively keep the leg straight and lift it off the bed. Leg straight. That's grand, okay? So once the leg comes up, you're stabilizing the pelvis. Again, you have a second operator. You cannot measure this yourself. You need a second person measuring the extension, okay? And back down again. You spin back around there, okay? Okay, there are a number of provocation tests, okay? So when you're looking for FAI, you want to see, do they have labral pathology? So there are two important tests. Number one is what's called which one do you have there? Or we move on to the straight leg raising. So anterior hip pain, labral pathology, lots of ways of assessing it. So the first thing is just bring the leg up against resistance, okay? What we're doing is we're tightening the iliopsoas and we're tightening the rectus femoris. As they tighten across the anterior hip capsule, it's putting on pressure on the anterior labrum. Again, if the patient gets pain when you bring the leg up and you're holding it there, get pain, all of a sudden you're replicating that labral pain. Second thing is, often you'll notice that the strength of straight leg raising is greatly reduced compared to the contralateral side that doesn't have labral pathology. So always, one of the first tests I use is straight leg raising. Okay, and it's important to look at the adductors, because often there will be referred pain down into the adductor longest area, and you want to make sure the adductors are strong. You can do this simply by using your fists in extension. Are you getting an even distribution of the strength? And again, at 45 degrees, just a little bit lower, but 45 degrees, and bring the legs together for me. And you're testing, you're looking for any pain. Quite often patients will feel a little click, that's quite normal, but pain on either side, again, can replicate a hip pain, but if the muscle strength is normal, and that pain is most likely coming from the labral pathology. Okay, the Faber maneuver, bring the knee all the way up. Again, to 90 degrees, we're allowing some external rotation, we're allowing abduction, back stabilizing the pelvis, and we're maximizing the movement. You're asking the patient, are they having any pain in the front of the hip, okay? And so again, what you're doing is you're tightening the anterior capsule, and you're replicating pressure on the labrum. You can measure the distance, the second person can measure the distance. You've got to get the patient on that side of the table, measure the distance from the knee to the table, and can compare with the other side again. And you can use that then as a measure of whether that improves or not after surgery. But as we talked about before, those two movements don't tend to be affected by FAI. So we use it more as a gauge for pain in the front of the hip. The impingement test is a classic test. Again, bring the knee into 90 degrees, bringing the hip into adduction and internal rotation. So these are the three movements that we've already described as being limited. And as you go into hyperflexion, you'll increase the amount of pain in the groin, and you're replicating, because what you're doing is you're bringing the femoral neck and maximizing the pressure of the neck against the rim of the cup, squeezing the labrum, and that will replicate your pain, causing discomfort at the front of the hip or groin area.
And based on about 1,200 cases for those sensitivities for those particular tests, it's about 70% Fader positive and able to replicate the pain for a Fader manoeuvre, and about 52% for Faber.
Okay, so the impingement test is more sensitive in diagnosing labral pathology than the Faber. Okay, so it's an important one to do. Now, those are the most of the tests that we do for impingement. When we come on to instability, instability is something that we, in the last 5 years, have really focused on regarding our surgery and our assessment of our athletes. We believe that microinstability is a big problem, and it's a big problem that, in my view, leads to impingement. And so you can see in that MRA scan, there's a lot of fluid on the scan. The capsule, which is the black line going around the hip, is very thin, and this person has a redundancy of the capsule. And redundancy of the capsule, a thin redundant capsule, often will allow increased laxity of the joint and present with symptoms. So again, when somebody's coming who I feel that there may be some instability, there's a number of tests you want to do. First of all, if you look at the screen, this is what's called a modified dial test. What we're doing is we're simply externally rotating the foot, okay, and allowing the capsule to elastic recoil and bring that foot back in again. So you see on the right-hand side, the patient has a redundancy of the capsule. They've got instability of the capsule. Again, when you see patients who have had arthroscopic surgery on their hip in the past that have not had a capsule repair, then often you will see that, okay? And so the capsule remains redundant after the surgery. So it's important we perform repair on all our patients. So again, to look at Craig's hips, again, we're going to get into external rotation, and we flick it back, and both sides are very symmetrical. They fall out to the same point. The capsule is working very effectively. We've got nice elastic recoil compared to our patient there on the screen. So that's one of the assessments, first of all, and I do that all the time, both pre-operatively and post-operatively, and we record any differences. If you're suspecting laxity or hypermobility, obviously the Beighton scale is something that is generally used. You're looking at a elbow hyperextension. It has come more than 20 degrees. You're looking at any finger hyperextension above 90 degrees. Does the thumb come back against the wrist? So you're assessing this on both sides. You're looking for any gross hyperextension of the knees. And the last thing is getting the patient to stand up and flex their spine with their palms on the floor. So these are all signs that they've got generalized hypermobility. And if they've got score of over 5 out of 10, this suggests that there's a hypermobility problem generally that could also then be affecting their hips. So looking for instability, there's a number of ways you can look for instability. Anterior instability is where the hip is unstable, similar to the shoulder. So we've got good bony support at the back of the hip, and we've got some instability at the front of the hip, because that's where we wanted to move most. Obviously, that's why it's most unstable that way. So to test it, you want to maximize, you want to try and bring that femoral head as forward as you can. You want to bring the hip back into external rotation. You want to bring the hip into abduction, and you want to bring it into extension. So what we're doing is I'm bringing the femoral head as far as I can in that position. Often I get a second person to hold the leg, and what you're doing is you're putting your hand in under the greater trochanter, and you're pushing and levering the femoral head forward. Okay, so what you're doing is you're maximizing the femoral head into that unstable zone. And if there's an anterior labral tear or there's capsular synovitis, then often the patient will feel very uncomfortable. Again, there may be some apprehension, like the shoulder apprehension test. We have one on the hip. Again, with gross instability, patients will often feel that femoral head starting to sublux with the pressure, and you know that the person has got some instability in the hip. You can do this also with the patient on their side. Okay, so same again, you're bringing it to extension, external rotation, and again, what you're trying to do is you're trying to bring that femoral head as far forward as you can, and you're pushing the femoral head at the back of the trochanter and asking the patient, do they feel pain? And again, on the front, probably the easiest way to do is bring the knee up into external rotation. And what you're trying to do is trying to maximize that rotation. Craig has some limitation of his external rotation, I'm afraid. You see his pelvis moving as soon as I bring his external rotation. But again, we're turning the femoral head forward, and again, behind the trochanter, you want to push down, and you want to try and get that femoral head moving forward. We'll bring it back there. Okay, so the other instability is posterior instability, very rare. And again, the direct opposite, back into adduction, back into internal rotation, back into flexion. When you're bringing the femoral head as far back and as far inferior as possible, and you're then putting longitudinal pressure back on the hip joint, trying to push that hip against the posterior acetabular rim. Is there any posterior labral tear that's causing pain? Any apprehension? Okay, but very rare. Somebody who's got a deficient acetabulum, somebody who's got previous trauma to the acetabulum. Okay, So other simple tests, there's the modified Thomas test you see here. The reason for doing that, we're looking for any tightening of the iliopsoas. What we want to do is we want to bring the knee back against the chest, if you grab your knee there. And what you're trying to do is, as the knee goes into hyperflexion, it flattens the lordosis of the back, and any tightening of the iliopsoas, you see the knee will start coming up, okay? And so Greg has normal iliopsoas, okay? But in somebody who's got quite a tight iliopsoas and quite uncomfortable, when the knee comes up, what you want to do is you want to then start gently pushing the knee down, and you'll replicate their iliopsoas bursitis or pain, okay? We see this quite commonly in patients who've got some a malrotation of their acetabular component after total hip replacement, okay? So the piriformis, just the last few things. Posterior hip pain is very common. It's very common with impingement. It's very common with instability. It's also common with capsular tightness. We get a lot of diagnosis regarding piriformis. It's a very rare diagnosis, but there's different ways of testing that. Just sit on the side there. There's there's about 5 or 6 different ways. What we're trying to do is we're trying to put pressure on the piriformis muscle so it squeezes the sciatic nerve. Again, so basically asking the patient to abduct, bring them out, and external rotate as tight as you can, and you're holding the legs as tight as you can, and you're intensifying that pressure on the piriformis. And if the patient has piriformis syndrome, then pressure on the sciatic nerve, they'll feel discomfort. Okay. The other way you can do it, you can just simply maximize internal rotation. You see it there, the Freiberg test. And again, because the piriformis is an external rotator, a short external rotator, by maximizing internal rotation, you're putting the stretch in piriformis, again, often replicating the symptoms. And you can do the same on the side with the patient. Again, go back into this flexion, adduction, internal rotation, and again, hand just behind the trochanter, and you're turning the hip out. You're tensioning that piriformis, and you're pushing on the piriformis. Again, the patient often will then feel and replicate discomfort. Okay, back we go. Okay, so in summary, it's very important to have a very structured way of examining the hip. You've got to look for impingement. If you're treating athletes, it's very, very prevalent, so you have to look for it, and you've got to assess the movements properly. If you're screening athletes, you want to measure those movements, you want to repeat them, and you want to repeat them in the correct way so the movements actually mean something further down the line. You're not getting different estimations movement, you're getting it done properly. Multiple pathology can coexist, and imaging obviously can support clinical diagnosis. But as we heard earlier today, histories and diagnosis are very important rather than imaging as a later. Okay, thanks very much. Thank you to Greg for being a great model. Well done.